I'm very, very, very concerned about the posture of the U.S. healthcare infrastructure currently to be able to detect, deal with, and, prevent something like this from being worse than it is. The readiness, the money not being there to help, and the information exchanging, all of these things are very concerning to me. And this is not anything political, gentlemen. I'm not a political person. I'm a healthcare professional who's just retired for the third time, seeing it from the front end. Okay. I'm concerned. And our infrastructure has to be maintained and enhanced. It just does, right down to everything, all levels, EMS, transport, you name it.
Hi, everybody. This is Chris. And Al, what time is it?
Yeah, way overdue time. It's time for another episode of Readiness Rewired, a healthcare preparedness podcast. And I am so glad the three-legged stool is all back with all three legs now. This is great. I'm looking forward to this one.
Yeah. So you want to introduce our guest, actually our returning, our veteran returning to duty here?
Yeah. So Chris, we've got Mike back with us, and Mike was on assignment for a while, really exciting assignment, and he's going to tell us a little bit more about that, and maybe you and I have some questions to throw out to Mike and see what's been happening in the world of emergency preparedness and others surrounding that. So, Mike, welcome.
Hey guys, thanks for letting me come back. I appreciate it. And my apologies for kind of abandoning you guys for a couple, 3 months. It's a little longer than I expected. But hey, you do what you got to do. So thanks for keeping up our end of the bargain going with the podcast. You guys did a great job. And you had some great speakers come in. And I think that was great.
Yeah, I'm sorry you missed a few of those. We had some great guests that joined us, but as we've kind of talked behind the scenes, we have some more great guests coming. So for those listeners that are wondering, hey, what's on the horizon for Readiness Rewired? We've got a few exciting things coming up that the three of us, I think, are all going to really enjoy. So for those listening or watching, stay tuned.
Yeah. But I think, again, Mike unretiring and getting back into the world of emergency management and reconnecting with some old peers, or peers, maybe they're not old. We're anxious to hear how it went and what your perceptions are of that world.
Well, I guess I'll start from the beginning. So here I am, minding my own business. I'm at my grandson's baptism celebration up in the state of Wisconsin. And so it's a weekend, it's a Sunday, got through the church stuff, doing the stuff at home, the little party afterwards and all the family and all that kind of stuff. And all of a sudden I get this text message. And it's our lead epidemiologist at the hospital, who I've always kept, our epidemiology infection control nurse, I should say, out of our Department of Epidemiology. And I've always kept a good relationship with those folks. Some of the best nurses I've ever worked with out of that group. Anyway, I get this text. Hey, are you in town? And I'm like, wonder why she's asking that. I said, nope, up in Wisconsin. She replies, oh, something's brewing down here. You might get a call. Oh, okay. I'm like what, man? What would you guys be bothering me about? She goes, we think we have a Lassa Fever case. I looked at my wife. I showed it to her, and she goes, what the hell's that? And I'm like, it's not good.
Yeah.
It's not good. And I'm sitting here kind of imagining, how can that be possible? And so, sure enough, I thought, you know, um, I better maybe start winding stuff here up because we were going to be leaving in a while anyway to come back to town. So, we started saying our goodbyes and whatnot, and kind of got on the road, and we're heading back. And so we were approaching the Iowa border, and I get another text, and it's from a person I've never heard of. It wasn't in my contact list, and it's a person that says, "Hi, I'm the new COO. Will you accept my phone call?" I looked at my wife and I showed it to her, and she goes, "What the hell?" And I go, "Yeah, I don't know." So I typed back, "Sure, okay." And so we're getting close to crossing the Mississippi River, and my phone rings. It said, "Hey, uh, we wanted to touch base with you about something. We think we have a situation here." And she went into the details a little bit about what was going on. And so, after going through the details of what this case potentially was, that they had contacted the state epidemiologist. The state epidemiologist concurred that this was a possibility. They contacted Region 7. They contacted the CDC. And all were in concurrence that this patient could potentially have this viral hemorrhagic fever offshoot called Lassa Fever. And they had indeed ordered testing to be done on this patient. And our incident command structure had been stood up that afternoon about 2:30, 3 o'clock. And the CEO is the incident commander and said, okay, well, if this is a possibility, we need to open up our special pathogens unit. And that takes, an order from the CEO, and they're the incident commander. So it was under the chief medical officer as well who ordered it. So they were in process at that time of starting to convert the unit, the space that we have, into biocontainment care. And
So
apparently bloods had been drawn. I'm sorry.
Yeah, Mike, just for those of us not in your world, you're talking about a space that is normally used for something else and has been used as something else for months and months, if not a few years. And nobody really knew how to switch it back or anything. That was kind of your forte. Is that right?
Well, and to give a little history and context, back in 2014, the Ebola outbreak in West Africa certainly caused everybody in the country to start to look at their preparedness to deal with something like that, at least from all the healthcare institutions, right? So our institution, being large and an academic medical center, looked at it as well. And so by that summer, going into August, September, we were making headway to look at what would we need to do to potentially take care of a case like that. I mean, that's no small matter. Ebola is like scary. So back in those days, there were probably 3 to 4 places in the country that could take care of a viral hemorrhagic fever case. And that would have been, Emory University in Atlanta, University of Nebraska in Omaha, NIH Bethesda in Maryland. They're mostly a research institute or whatever under Dr. Fauci, but they had 1 bed that they could take care of a patient. And then St. Patrick's out in Missoula, Montana, was actually associated with a U.S. military installation out there for biological warfare. And they did have a unit there that was not offered to the public, but they had the skill to deal with something like this. So those were the only places in the country that could do this. So we looked into what would we need to do to try to take care of something like this. And we picked out a space in an intensive care unit that dealt with surgical and neural cases. It's one of the hottest, areas in the facility. It's 36 beds, and the sickest patients probably in the facility, as far as adults go, that's where they go. But there was a 4-bed cluster of rooms that were kind of off by themselves in that area. It could be isolated, it could be locked down. And the biggest kicker was that it was on its own air handler. And so the air system, the HVAC system was standalone, and those rooms were negative pressure. And that exhaust coming out of the rooms was piped directly to the rooftop, 25 feet from everything else. And so it was like the ideal sort of biocontainment beginnings, if you will. And so what we tried to do is figure out, okay, if we needed to do a viral hemorrhagic case, how could we convert this room and make this happen, this unit? So that's what we did. And then, but I'll tell you, by October, if you'll recall back in October of 2014, what happened in Dallas. You remember that, gentlemen?
Yeah. A nurse.
Yeah.
Well, at least
our first
nurse,
Ebola case, a returned traveler walked into a hospital in Dallas, first one in the U.S., and ended up exposing staff. 2 nurses actually became ill and were exposed to and became ill with Ebola. And I can't imagine, every hospital CEO in the country was scared to death. It put the fear of God into them that could happen in their place. Because you can imagine what happened to the admissions, procedures, outpatient stuff just went tanked, for that facility for a while because of the stigma and the publicity. And so no CEO wanted to deal with something like that. So at any rate, I've never seen so much money and effort go out the door so quickly between, the end of September into about the middle of November in my life, and I'm sure you guys, when you were doing your thing, you guys were doing what you needed to do too, right?
Yep.
Trying to get ready for potentially something like that walking in and devastating, your healthcare system.
While saying that, though, the frontline preparations, other than trying to maintain some composure and containment, are still pretty simple compared to not only you have air handling, but you had to have, be able to get people in and out, do procedures, bring equipment in and out. You had your waste handling. I mean, it's a major undertaking, and that's why there's so few facilities when it comes to something like this, and there has to be transitional space and education and so on, right? So, I mean, it's a huge undertaking, and there's very few sites to this day that can still do that. Is that a fair statement?
Yeah, you want the real numbers. I mean, so as it sits right now today, there are think about this. How many hospitals are there in the United States? There's about upwards of 6,000, right?
Okay.
Something like that. Might be a little bit less, but I think, if you look at the numbers, it's somewhere in the neighborhood close to 6,000 hospitals. Out of 6,000 hospitals, there are something like 65 beds in the whole country right now, after all these things have happened or whatever, that could potentially take care of a case like this safely. And they're really housed in 13 facilities. So there's currently 13 federally funded level 1, what we call level 1. They're kind of like trauma centers, right? You got trauma 1, trauma 2, trauma 3, trauma 4. The National Special Pathogen System of care, which is basically been restructured within the last few years to mimic the trauma system, okay? They have level 1, level 2, level 3, level 4 as well. And so level 1s are funded federally with, I believe they are 5-year grants at a time. And those 13 hospitals receive a certain amount of money to be the regional resource, regional level 1 care center, and they match up with each of the 10 FEMA, DHS, HHS regions. And there are a couple, 3 regions that have more than one due to their population. And so, for example, Region 5. Region 5, if you remember your FEMA, HHS regions, is Minnesota, Wisconsin, Illinois, Michigan, Indiana, and Ohio. For the longest time, they had one level 1 Special Pathogens Treatment Center, regional Special Pathogen Treatment Center, and that was located at the University of Minnesota, okay? Serving that whole huge area, which, wow, that's a chunk to bite off, right? And so they put another level 1 over in Grand Rapids, Michigan, with a group called Corewell Health. And so those 2 serve that large region. Our region here in Region 7 only has 1, Nebraska, right? Nebraska Medicine. Over in Chapel Hill, North Carolina, there was a new one put in there to help that region over there. And over in Washington, D.C., there's a children's hospital over there that was added. So that's where we went from 10 to now 13. Every other region in the country has got one regional biocontainment unit, level 1 center. And then there are what are called level 2s. We ended up being a level 2. Level 2s are kind of like trauma level 2s to level 1s. Level 2s and level 1s in the trauma world are supposed to do about the same kind of care, right?
Yeah.
The difference being residency training, research, that kind of stuff. So level 2s should be able to provide about the same level of care as a level 1 in the special pathogens world. There might be some exceptions, some specialty stuff that might not be able to be done. It depends, right? And there are, there's 13 level 1s, and I've been hearing there's somewhere left about 30, maybe, level 2s out there in the country that are still on the list. A bunch dropped off because we don't get any funding. Level 2s, level 3s, which are test centers, where the patient could be brought there suspected of a special pathogen, and they could be brought to a level 3, which should be able to hopefully safely care for that patient while they're being tested. This would be just a few days. And if they become then positive, they're shipped out. They're sent to a level 1 or they're sent to a level 2. That's the way it's supposed to work, right? So here in our state, we've got 2 level 1s, 2 level 2s, 3s. Here I am. 2 level 3s in our capital city, and that's it. We're the only level 2. In the state of Illinois, it's kind of interesting. They had 2 level 2s and a level 3, but the level 3 dropped out when the level 2 dropped out when the funding went away. So there's only 1 level 2 serving the entire population of Illinois. Sadly.
Including Chicago?
That is Chicago. There's 1 in Chicago.
Wow.
There used to be 2, but again, without any funding, there's no funding for level 2s,
Right.
level 3s, and whatever. It's expensive to keep a program like this up and running, and it's tough, which is one of the issues, obviously, we dealt with here. So anyway, that's how the system of care is supposed to work. Being a level 2 this day and age is a serious commitment by the institution because you're out there by yourself. It's the institution that's supporting it. So the staffing, the funding, the exercises, the training, everything like that, it's on the institution's dime to maintain it. And so they have to be pretty darn committed and have it part of their mission to keep that up.
Right.
Kind of makes sense, right?
Yeah.
So anyway, I hope that answers your question.
Yep, absolutely. And the Lassa fever is typically where in the world is it typically originating?
So Lassa fever. A little history about it. It is a viral hemorrhagic fever. If you look at the big hierarchy, you've got Ebola up here, which everybody knows more about, right? We all learned about it back in 2014. It's the worst of the bunch in terms of its transmissibility. Like one little tiny virin is all it takes to get into your body, and that can make you sick. That's the dose, if you will. And it's got a pretty high mortality rate, although there is a vaccine out for a couple of the variants of Ebola now, but not all of them. And so it's a concern. So there's Ebola. Then there's Marburg. Marburg is another viral hemorrhagic fever that's out there that's probably number 2 on the list as a cousin of Ebola in terms of severity. Then there's Lassa fever, which is number 3 on the list probably. And then there's another one called Crimean Congo hemorrhagic fever, CCHF. That's kind of number 4. So I think of those 4 as kind of related and cousins. Okay.
Gotcha.
Ebola being the worst cousin of the bunch. All right. Now, where do you get it? Well, it's endemic in certain parts of the countries that Ebola is. So if you look at West Africa, it's endemic in West Africa in several countries there. And the case that we were potentially dealing with was a return traveler from Liberia. And there's 4 counties in Liberia where there have been ongoing hit and miss cases of Lassa fever that popped up, which is what helped our epidemiologists figure out that's what this might be. So yeah, that's a little bit about it. Now, a little bit about Lassa in terms of its, I guess, morbidity, mortality. Really, only 1 in probably 5 cases of Lassa fever do people get seriously ill. There can be people running around with Lassa fever and be asymptomatic, just like COVID was, right? You could be asymptomatic and have it. So it could range anywhere from asymptomatic up to you are severely ill and you end up in the hospital in an ICU. Again, only 1 in 5 cases end up like that. And overall, though, of all
they're all
Lassa fever,
contagious of all those
right?
strains.
Oh, they're all
Right.
contagious.
It's not
Absolutely.
okay. So Al, you're contagious.
Lassa is not as contagious. Move down the list. It's not as contagious as Ebola. Okay, which is good. Okay. Overall case fatality rate, we call it the CFR, 1%.
Oh wow.
So all the people who get Lassa fever, only 1% of them die. However, if you're one of the unlucky people to have one of the 5 that has to go into a hospital in an ICU, now your case fatality rate jumps to 15 to 20%. Okay. And taking it even further, and the reason I bring this up is because we had a scare like this. If you have a pregnant female and is sick with Lassa fever in their 3rd trimester, now your case fatality rate for the fetus is 80%, and for the mom is 30%. So pregnancy,
Scary.
yeah, not good,
Wow.
man. Case fatality goes way up in pregnancy, and that's pretty scary. So that's a little bit about Lassa.
Okay.
And so the case that popped up in our state was a returned traveler, person who was U.S. citizen, lived here in this country for 20 years probably, and returned back to native land for about a 4-month stint, bought some property, was constructing a residence, thatched hut, that kind of thing, thatched roof hut, and building this in this village in this particular county called Bung County. And that's how our epidemiologists sort of put 2 and 2 together and said, wow, they've been having some hit and miss ongoing stuff. I think the last case was in 2023, maybe, but that tipped them off. And so,
Wow.
return traveler. Yeah, so I guess, a little bit about the situation. People come back to the country and, this person came back in early October, was fine, no symptoms, no nothing. But like a lot of these cases, exposure and then incubation period is the next thing, right? How long has it got to sit and cook in your body till it starts to make you sick? And incubation period for this particular viral hemorrhagic fever is somewhere between 2 and 21 days. Remember Ebola? That's about what it was too, right?
Mm-hmm.
Yeah.
Mm-hmm.
So anyway, I think traveler came back on the 7th of October after being in their original native land for about 4 months, and then came back about that time, 7th, and by the 15th was symptomatic. And just thought I caught something, whatever. It could be lots of different things. So didn't really seek care. By the 22nd, sought care at a doc in a box. You walk into a doc in a box and say, hey, man, I'm sick. I got this, blah, blah, blah. Well, the docs there were kind of like, not sure about this.
I'll see this every day.
Not so great.
Yeah.
Right? You see it every day. But the travel history, I think, did tip them off a little bit. They were thinking malaria, maybe, or something like that. So they actually called EMS and had EMS transport the patient to a larger community in this part of the state. And patient was admitted. Okay. Was stable, febrile, symptomatic a little bit, but, really pretty stable. They spent the next probably 4 days working on this case, and really we're getting nothing but negatives in the testing, the labs. They had CT, X-ray, all that kind of stuff. I think they did an ultrasound of the pericardium, didn't see anything there. So, where's this coming from? What is this? The labs are all coming back negative. So about 4 days into it, patient was starting to deteriorate a little bit. They started not responding as well and things like that. So I thought, all right, need a higher level of care. So I think at 2 a.m. Was sent our way to our facility, and the admission was in the middle of the night. And so our epidemiologist woke up And what was interesting, um, what tipped them off, as this was weird, is that the admitting ICU doc in the middle of the night, which is residents a lot of times, right, in big centers, ordered a viral hemorrhagic fever test for Ebola. Now, that set alarm bells off in pathology to start with. It's like, what? Who's testing Ebola? Viral hemorrhagic fever? Are you kidding me? Well, that got the epidemiologist woke up too in the middle of the night, and they're all going, what's up with this? And so they started looking into this more. And by the early morning, the epidemiologist said, all right, everybody, make sure they get their PPE on and somebody get in there. We need more history because there just wasn't enough history. Couldn't figure it out, right? Looked at all the negative labs and all this stuff. It's like, okay. So they went in there, and the patient happened to have some family members there who were able to relate more story. And that's when all this was sort of kind of, the travel history was more precise now. They got more info. And it's like, wow, okay. And it got right down to the county that was visited. So the epis start looking into it and see that, ooh, this has been having some on. So suddenly Lassa Fever gets to be put on the differential. And that's when our epidemiologists called the state, and then they called the CDC, and blah, blah, blah. So that's kind of how it all came about. So what's the message here? What's the take home? Well, every piece in the healthcare continuum, from right to when they walk into an urgent care or a quick care or a doc in the box, has to search for travel history. Signs and symptoms, travel history. Have you traveled outside the United States? That cannot be seasonal. It has to be 24/7, 365. Everybody in the country should be doing this, because this stuff, hey, if it can happen in our state, of course it can happen anywhere. Return travelers are coming back from everywhere. And it's not just foreigners coming in. It's people, our own residents are going places in the world where this stuff can be brought back and jump onto a jet with them. And they're not going to know it because they're not sick. Yeah. That makes sense, right?
Yeah, well, and the thing that, I'm listening to you, and the thing that jumps out to me as scary yet fortunate is because, Lassa, you mentioned about 1%, of the people can be contagious or can get Lassa from someone else. And think of all the people that this person touched and was in interaction with, not only in the healthcare system, but in the community and everything else. And if that was a bigger number, that would be really scary. Luckily, everybody was fortunate, and I don't think there was any other cases after the investigation and checking, correct?
Yeah, I can tell you, I can go into that a little bit more. Just to be kind of clear on this, the 1% is the case fatality rate, not the transmission rate.
Okay.
It's more contagious.
So, so it's more contagious than that, but not as contagious as Ebola. And that was fortunate, because if this had been Ebola, I can tell you how many people were exposed to this person. I was exposed to him because I worked in a unit, right? So,
and before they knew it was Lassa,
exactly.
They probably weren't taking all the PPE precautions, doing the regular routine stuff and going through. Yeah. So that, wow.
Hey, and that just goes to show how important standard precautions. Chris and I have heard this all of our careers, at least gloves. Maybe you might need a mask, standard precautions. It's called universal precautions for a reason.
Yeah.
I think that probably saved a bunch of people.
And Mike, I wanted to circle back to the travel history that you talked about and ask you a question too. I don't believe, for example, Lassa Fever, there's a test that's in every, doc in the box. And so it's not like you could do broad spectrum testing and say, okay, this is what it is. That's where that travel history and being able to go to some of the websites, which now are becoming more difficult to find because they're not being funded, but that's where you get the surveillance tracking, right? So I don't know if you want to emphasize that.
Our epidemiologists being able to access information that showed Lassa Fever was endemic and potentially, ongoing in this particular county, in this particular country. That kind of information is absolutely critical. And you're right, because of recent changes in our government's posture on this kind of information is not as readily available to a healthcare practitioner, which is criminal in my mind, because it really handcuffs their ability to do the work they're really needing to do to protect us, you know? So anyway, it's unfortunate.
Yep.
Yeah. So point being, yeah, this particular disease, if it had been something else, things could have gone much worse. Okay. So the fact that it was a second or third cousin of Ebola made it better. But there has not been much of this in our country. In the last 50 years, there had been, I believe, 8 documented cases of Lassa fever in 50 years of the U.S. So you can imagine everybody, sitting there going, what's the likelihood of this being positive? Everybody's like, eh. So I credit our epidemiology folks and the state epi talking to the CDC, because they had to get the approval for testing. And Chris, you make a good point. Nowhere in our state could we test for Ebola. Or I'm sorry, Lassa. That was not a test. Our state lab could test for Ebola, but not Lassa. The nearest place that could do Lassa testing was Omaha, Nebraska. So what they had to do was that when this kind of hit the possibility list, bloods were drawn and sent across the state. They put it in a fast courier and they drove the test material, the bloods, over to Omaha to their lab so they could get the test done. And so we had to wait. And then that's only presumptive testing. Then the blood has to be flown to the CDC in Atlanta for confirmatory testing. So there's presumptive test, and then there's confirmatory test. And so you really don't have a true test until the CDC verifies it. And you can imagine how long that can take.
And the interesting thing too, Mike, because I know after this started developing, there were other major hospitals reaching out to me because I was in the area of, some of this activity, and they said, hey, can you reach out to Mike and see what's happening there? So we had that network, and that's the partnership that we've all got going on that is so important. Just the communication of, hey, what's going on, and this is what we hear, and that type of thing was really cool. And I really, even though I'm non-clinical, I really enjoyed the fact that, hey, we got this relationship with others who are interested and concerned and want to make sure what can we do, and what's going on. And I recall that special pathogens unit because, going back to that 2014 and the Ebola stuff, here I'm a non-clinical person, yet I was fortunate enough when Mike ran an exercise out at his location. He said, hey, come on along and come out here and be an observer, And so I was actually assigned as the cameraman for the walkthrough. And I mean, I followed the patient through hallways. I followed it up into the room. I watched the doctors and the nurses. And as a non-clinical person, it was really cool that I got to see that close in an exercise, not in a real event, but in an exercise of, then you think, oh, this is really cool. We're preparing for something, but will it ever be used? Well, here
10
we
years
go.
later.
Yeah,
10
here
years,
we go.
man.
Right. Yeah. And all of a sudden, and when this all was unraveling and developing, I could picture in my mind is, yep, I know the area in general. I was there. And it was, so I could relate a few things to people that were asking me, because I was trying to stay out of the clinical side because that's not my expertise, obviously, but pretty neat stuff. And that's all preparedness, right?
Yeah, absolutely.
Hey, Mike, a term, just to clarify too, I think you use special pathogens. Do they also still use the term high consequence, low frequency, high consequence? What's the current
You
vernacular?
see that. Yeah, I think the term they really prefer nowadays is special
Okay.
pathogens. There are others though that are throwing the high consequence infectious disease HCID. I think, for example, Emory's unit is still called their high consequence infectious disease unit or something like that. So that terminology is still floating around out there, but I think from a preparedness perspective and the way that this National Special Pathogens System of Care is being structured and its framework, that's probably the better term, the more modern term. Yeah. So
Okay. So
anyway,
if people want to
yeah,
Google it or whatever, that's where
yeah,
they go.
absolutely. You should
Cool.
learn. So I guess, kind of finishing the story.
Mm.
So I this phone call with the COO of the hospital. I'm like, will you come back? Because my successor, who had, I had retired 3 years ago. My successor, who came on board, had just left the institution 2 weeks earlier to take a job out in Colorado or something. So they had nobody who would do this function. I was in my role back in the day. I was the operations manager of this special pathogens unit and the emergency manager for the facility. So, and helped kind of construct the thing and design it. So, you know what? I said, she said, well, will you come back and help? And I go, of course I will. I mean, are you kidding me? These are the people that I've worked with for how many years? The nurses and the people, I care about. I mean, if this is really a possibility, if there's something I can do to keep them safer and keep this thing contained and the way it's supposed to be, sure, I'm going to do it. So 4 hours later, I found myself with an emergency appointment, a badge, and walking into the facility at 7 p.m., watching everybody scurry around, get the unit ready.
Now,
And so,
emergency appointment
yeah.
means that they fast tracked your employment, not you needed to get an appointment to be checked out.
Yeah, they had HR on call and they emailed me a contract. And as a temporary employee, I wasn't a contractor per se. I was
Wow.
actually made a temporary employee within an hour or two. It was strange. And so anyway, when I got there, I found out some things. So I didn't know what the situation would be after 3 years, what had been going on with the unit and all that. I found out we went from 35 trained nurses to 14 because of burnout, COVID burnout, attrition, things like that. So we're down to 14 nurses, which is problematic because you need about 5 on duty at any given time when you have a situation like this. I found out they had not done any exercises in that period. There was no funding. And they had done some training. I think there'd been a couple of trainings to try to keep people up, and they, maybe had a one or two new ones here and there. But, they'd done a couple of trainings and no exercises that I could determine. And so you can imagine, I walk in and it's like, wow, a lot of things that I put in place, things that were supposed to be done, things like that. Yeah. So I was running around, trying to spritz things up, correct things, find things, everything, my bunker that had all my stuff originally had been taken away and was used for something else now. So everything got moved and stuff got lost. And anyway, so it was a challenge to get it to the readiness that I remembered that we'd done. We were getting pretty close by about 10 p.m. And I remember I was in the patient's room with nursing director, and we're getting everything sat out for doing additional labs and the treatment that was going to have to be done, because we were learning, at least I was learning, that over the last several hours, patient's condition was deteriorating. And they were in an ICU and receiving ICU care, patient, but had to be put on a ventilator, and blood pressure was dicey and lots of different things like that. Organs were not doing well. So, there's only been in our facility a few hours. So anyway, by 10 o'clock, we're getting close to being ready to move the patient to our unit. And I looked over my shoulder and I saw, you guys, I have to tell you, one of the most welcome sights anybody could possibly imagine in that situation. I saw
Al?
3 people walk into the unit.
No.
Yeah. I saw 3 people walk into the unit. These were our instructors who taught us how to do biocontainment from the University of Nebraska's
Wow.
biocontainment unit. 3 of them had jumped in a car because they found out that, we had a possibility. It was being tested. Blood was coming their way to be tested in their lab. And those folks over there said, maybe we ought to go help. And so they called our incident command and said, hey, we're offering, would you guys like to have us come over? And thank God my leadership and whatever said, come on down. So they walked in, and I'd had a 10-year relationship with these people. And so I cannot tell you, and two of the nurses, there was 2 nurses and a coordinator. And so the 2 nurses had taken care of the 3 Ebola patients back in 2014. So these are experienced individuals. These are rare people in this country who have had that experience, right? And they're walking in to help us. Telling, man, that was just,
Awesome.
I choked up. I'm like, oh my God, what are you guys doing here? And they looked at me and went, what the hell are you doing here? We thought you were retired. So it was a big surprise for both of us, right? And I'm like, oh my God, hugs. I mean, I'm telling you, it was a moment. I'm telling you, that was 10 years in the making. But they got right to work with us. They got with our staff. We got them into their PPE. They were helping. They went over the care plan with the staff. They're helping the staff get ready for this. And it was fantastic. So about an hour later, the team went down to get the patient. I'd do some quick, just-in-time training for our EBS folks who do the mopping. I mean, the floor had to be mopped all the way from where the patient came all the way up. So there was a mop and a spill group, and security had to be just-in-time training. So all this stuff. And so patient was brought up. It was in critical condition and very intense efforts. So the doc that was on duty is one of my favorite doctors of all time. He was the first doctor to take care of somebody with COVID in the state of Iowa. So he was actually the receiving doc when we put COVID into our unit in March of 2020. And so he was on duty, and he may have actually been called in. But he was part of our special pathogens care group from the start. And this guy's a rock star, man. And so he got him into his PPE, 3 nurses in full gear, and then the other 2 outside in the warm zone. And so 3 nurses and a doctor at the patient's side, and they worked intensely to try to stabilize him. And I remember about 1:20 in the morning, I'm standing in the cold zone talking to one of the nurses from Nebraska who was in her gear, and she was monitoring our staff, everything they did, and was helping with things and procedures and just being a watchful eye, making sure nothing bad happens. And her and I were talking, and all of a sudden my phone buzzed, and I looked at my phone, and it was our lead epi nurse had texted that the testing in Omaha came back positive. Potentially for Lassa. So I looked at Angie and I said, you ain't going to believe this. She looked at it, and her eyes just went like this, because the team in Nebraska had no inkling that this would be positive. Thought, this is just a scare. Bam. So now we have the 9th case in U.S. history over the last 50 years of Lassa fever, and it's sitting in our state. Who knew? So anyway, she went and told the team, and they continued their work. At about 4 a.m., things were pretty stable. So we swap out crews and bring in another crew of nurses and another doctor. And so they shower out, right? So when you're working in this kind of environment, you don't wear your own underwear, your socks, your clothing, your no jewelry, no nothing. Everything comes off. Everything gets put on that you wear is disposable. Okay. So then all that stuff gets disposed of. It was intended to go into our autoclave and then treated like waste, and then they shower out. So it's a shower out situation. That's BSL 3 plus, BSL 4. That's the highest containment capability you can have. One little piece of bad news when I showed up is the autoclave didn't work. Our waste processing autoclave would not boot up properly, and the doors wouldn't open. So we had no way to treat what was now going to be category A, highly dangerous infectious waste. So we just had to let that stuff build up. And we had, our facilities guys called for an emergency repair of our autoclave. And they said, oh, well, we can't be there till sometime tomorrow. Great. Okay. So now we got all this waste building up. And no way to treat it and whatever. So That was going to be my job. I was going to run the waste through the autoclave, and that's what I always would do until somebody could take over for me, and that was my job. And so I had no job. I couldn't process the waste. So I just took care of mopping and doing, in fact, coordinating things and stuff. So about 4 a.m., everybody was pretty whipped. So the new crew came in. The nurses from Nebraska went over to a hotel for a couple hours, and I went home for a couple hours. I didn't sleep because I knew Incident Command was going to be brought in about 8 o'clock in the morning for a briefing. And that's when, we had to go deal with the fact that we now had a positive. And you guys know Incident Command, right? Once you got something like that, that's of a national sort of interest. How now it's all about communications. So now the PIOs, public information officers, everywhere, up and down the chain, right to the CDC. We're now trying to figure out how we're going to communicate this internally, on our campus, on our community, in our county, in our state. And the CDC's running the show, man, because they were going to put it out first. So that was an interesting Incident Command briefing, you can imagine. And then, unfortunately, right after that briefing was over and things, the patient's condition deteriorated considerably. And so, basically the physician, and this is the way it was pretty much set up with Ebola, there are certain things we will do and certain things we can't do and expose the staff to. And so, Chris, you probably have heard the term chemical code. Yeah. So that's when you use the resuscitation drugs and techniques and things like that, which don't allow a lot of exposure to the team doing it. And so, for example, chest compression, CPR, that's off the table. You can't. And so, we used electrical therapy. Chris knows what this is, cardioversion, right? So that was used a few times, and the medications were there.
I know what cardioversion is. I've had
El's experienced that.
Yeah,
so,
I have.
So we did do stuff like that. Patient was on dialysis the whole evening, and all these things were done, but unfortunately was not resuscitatable, and so unfortunately the patient expired late in the morning.
Now, Mike,
and
all of those were done in a containment unit. So there's
Yes.
consequences to bringing all that equipment into a unit like that, right?
Yeah, now all the equipment that's in there is now contaminated and has to get disinfected specially,
Wow.
right? But worst case scenario is the fact that, when a patient dies of a highly infectious disease, you can imagine the pathological load in the body that would cause death. Viral load, for example, the viremia it's called. The patient now is the most dangerous and most contagious you can possibly be. Okay. So now is when it's the worst. And so now things have to be done so meticulously to be able to care for this patient as a decedent, far more considerations than, for example, when the person was first admitted to the first hospital. Okay. Mm-hmm. They're nowhere near that contagious at that point, right? So, yeah. But I'll tell you, we built this unit and this capability to serve the patient and to get positive outcomes. And this hit our staff hard. I mean, we didn't have the patient for very long. But unfortunately, the high moment, the adrenaline, all the effort and things like that to do everything we could, and for naught, unfortunately, and it just was not in the cards, unfortunately, from a timing perspective. And so it really hit our staff hard. And I remember right when this occurred and we were unsuccessful in resuscitation, the staff just stopped, and then they called for a prayer. And so they began a prayer thing for the patient and the family, and then once that was over, then they knew they had to get to work, because now the room was major contaminated. Everything's contaminated. They now need to start dealing with that. And so that's what started.
And what comes to me, working in emergency preparedness just in general and working with you guys over the years, Mike, you mentioned, you had been gone for 3 years. There was some activity, but no real priority focus on the special pathogens unit and all the equipment, keeping that up to date. And it kind of shows. I'm sure the outcome would have been the same with that patient, unfortunately. But the true importance of readiness, the true importance of preparedness, it's kind of like well, we spent a lot of money and nothing's happened in this 3 years. Yes, but it, it, you have to be prepared. Kind of like what all three of us and all of our listeners do. We all buy car insurance hoping we never get in an accident, but we have car insurance. We have homeowners insurance hoping nothing ever happens to our home. Well, money has to be put into preparedness for healthcare, for these special pathogens, for all the different crazy things that we truly hope never happen. That's how I look at this. But this event kind of shows the importance of why do healthcare systems spend money on things like this? Because it's for the good of our community, and it's for the for the preparedness of making sure that we can do the best we can. Sometimes the outcome isn't always what we hoped for, but did you guys do the best you can? Absolutely. And it just took a while to kind of energize it and inject it with a little bit of life fluid again to get it going. But wow, think of if you had never done that before. you know uh
Well,
that
we had never had this kind of admission before. And so,
yeah,
the drills and exercises we did prior, 2, 3, 4 years ago. Yeah. I mean, it's not like we were starting from scratch.
right.
I mean, but were things as fresh? No. Were things done, slower and took longer to get ready? Yes. But did our friends from Nebraska help us? Oh my God. They were just critical to this. So to have a level 1 that can actually come on site and help and provide guidance and things like that, that was just incredible. And so my message to everybody out there is, if you don't have the time and funding and whatnot to do everything you would like to do to be prepared, the system is out there that can help. And so they're a phone call away. Everybody should know who their level 1 center is for special pathogens, and it's on the website. You can go to NETEC, NETEC.org, NETEC.org, and read all about the Special Pathogen System and the network of care, and the contact information for every single one of these 13 I mentioned are out there, so you can get a hold of them and get to know them, find out who they are, establish a relationship, and maintain that relationship, especially if you're the emergency preparedness person. And I'm sure your infection control people or whatever are going to be right on board with you to do that.
The relationships and being prepared, is so important. You're right. And even for the local or the common day-to-day stuff that goes a little bit off kilter, having those contacts are we've seen it time and time again, are so important. I agree. Wow.
Chris, you look like you have a question or a statement of some sort.
No,
He's thinking. He's thinking.
I think we kind of glossed over the end there of that acute episode, but like so many of those, there's a huge cleanup and return to its ICU capabilities. Did you want to address it at all, just so people can appreciate what that involves?
I could mention it. The thing is, initially after the patient expired, right when the patient was still in the room, nurses immediately start bleaching stuff. They bleach everything they could bleach as far as equipment, the bed, the walls, literally the floors, gathered up all the category A waste, the red bags, and we have them sequestered in another room ready to be processed. So we had to get all those things gathered up. We ended up between the two units with 80 bags, 80 bags of red category A infectious waste, which is problematic because we have no way to process it. We have no way to dispose of it at that point of time. So it just had to be staged and locked up in the unit. And then after that, it's all about desiccation. And so, we left the negative air pressure system on, and it's 20 air exchanges an hour in a unit like that or better. Normally it's about 12 in a standard negative pressure room in a hospital, right? So a dry virus is better than a wet virus. And we were told by our friends out of NETEC and Nebraska that if we dry that virus out, if it's on an environmental surface, within about 72 hours, it's probably dead. And so drying is a good thing. So we just left our negative pressure system running to dry everything out in the room after we did the initial bleaching and stuff like that. And then we just walked out of the room. And then basically the decedent care piece, boy, I could go. I spent an hour talking to our friends down at Barnes Jewish in St. Louis last week or the week before, just going over decedent care because it's such a process and it has to be done so carefully. That wasn't able to be done until later that day, because here's another issue. Planning wise, back in 2014, HHS or IDPH back at that time tried to get a mortuary service that would sign on and be willing to help out in a situation like that to help a family whose loved one had died of a viral hemorrhagic fever and then final disposition. Nobody was willing to go on record wanting to do that, and they were fearful of how it would look if the public found out that somebody with a viral hemorrhagic fever had their funeral or was processed through this XYZ mortuary service or whatever it was. And so we ran into the same thing. We had never been able to find somebody in our state that was willing to work with us after something like that happened. And we had a list of 18 people that HHS worked on that day, that Monday, the 28th, and wasn't having any luck. Nobody was willing to help. And so, we had a plan that I had purchased a single body cooler, because we have a large decedent care center with a large cooler, can hold about 16 decedents. But you're not going to put a case like that in there. And so we bought a separate single body cooler that we put out on our loading dock area of our garage area for our decedent care center. And it had been used for other things over the years, but we had always had it. And so that was our plan if HHS couldn't come up with anybody, but they finally found one later in the day. And so we were able to have a nice virtual family spiritual service, but it had to be done virtually. It had to do on a secure video platform with, the minister of their choice, all the family members and things like that, done from, our staff with in the patient's room. So they could say their final goodbyes, had the prayer services and whatnot. And here our Nebraska friends were just critical on that deal because they had dealt with that. One of the 3 Ebola patients that they took care of back in 2014 also came to them very late in the process. They couldn't help them. They expired within hours. So they had to do all of this stuff. So they are experienced in that as well. So they helped our team conduct that and gave the family their that was about a 2-hour deal. And then about 7 p.m., I called the ME's team in, medical examiner's team from the county. They came in their gear, brought their stuff. And with our team, it took us probably the next 2 hours, 2.5 hours to be able to do things so that we could safely bring the patient out. And once we did the things we were told, and, I'd written a protocol for years ago, you don't really need a whole lot of PPE at that point. So patient was taken directly down to our decedent care center. Patient was transported to this facility that agreed by one of our 4 EMS services here in the state that were trained in special pathogens. They'd already been doing some transports, some PUIs, so they were already tuned up and going. And so one came from out of town to come do this, and they were able to take the patient to their final disposition, and then that facility then helped the families. So then the cleanup was probably another week. It took us a week to get everything back up and running and to the point where we felt it was safe and we could resume normal operations. And it was a good thing we did that because then we had a PUI come in, person under investigation, who was 3rd trimester on her 4th child, who had a high potential exposure and was within a day or 2 of delivering. And so we had to bring her into the unit, and we did obstetrical care in the unit, the same room we were using. And so our OB team came in and assessed her, drew blood, testing off to Omaha. Patient was then let go out of the unit because they really weren't sick and they weren't symptomatic, but just needed to be tested. And 72 hours later, had to bring her back in for a second test because you need 2 negatives, So brought her back into the unit, and then she was getting close to delivering. And so we needed to get that second test of a negative. And fortunately, our state lab had just gotten the Lassa Fever test validated, so we could now do testing locally in town. So that helped a lot. So she agreed to be admitted. So we admitted her into the unit, and we were getting ready to do a C-section or a vaginal delivery. And the other room we had in our unit, we were getting it prepped and ready to do neonatal care. So nobody in the country, nobody in the United States has ever had to do obstetrical and neonatal care for viral hemorrhagic fever. We were the first to actually face that. And so we were prepped for it. We were ready to do it. But then fortunately, that second test came back negative. And so the blood then was flown to the CDC by jet, and we got the confirmatory negatives. So then within hours, she actually went into labor and delivered her child, but did not have to do it in our unit because we had the confirmatory negative from the CDC. So yeah, that worked out pretty well. So we did not have to do any of that kind of stuff.
Wow. So, Al, retirement never looked so good, did it?
Boy,
Dude, this old guy, I'm telling you, you guys are all my age or close to it. This is hard on an old man.
Yeah.
I did 26 hours straight first shift, and
wow,
dead.
How was it?
And that whole week, dude, I can't take that, man. Old guys, come on.
But it's a passion.
Well,
it's a passion for you. You did a great job, I'm sure. And they called the one person in the area, relatively speaking, Wisconsin, that could do it, and you pulled it off.
Well, anybody would do the same thing. You guys would do the same thing too. I mean,
we haven't
even
a clue.
Out like you are.
No,
you're going to get called. It would happen.
Chris, you would have a clue. I would be clueless, but we're all going to jump in and do what we can. And, I listened, Mike, you did a webinar with a couple of other people on this subject, and I listened to it. And truly, when I first listened to it, I thought, oh my gosh, what would happen if I was involved at any level? But you mentioned something a little earlier. You'd reach out to all your partners, you'd get the right people involved, and all of a sudden the team starts coming together. And I've seen it. You guys have seen it too in exercises, and maybe some of our listeners who have done exercises have seen it. That they come out of the woodwork to help when you put out the call and says, I can't do it by myself. I'm going to escalate this baby up. And in this particular case, it was really, really important that those partners, came in. And I listened to that and went, oh, I'm glad I wasn't around. I'm glad I was retired. But for those who are still in the game, know that help is out there.
Here's the good news of all this. The bad news is we couldn't save this patient, which just killed the staff. It was tough on it. But there were 170 people exposed to this patient between the first place they went for care, the EMS crew that transported him to the first hospital, all the people in the first hospital, were potentially and had to be gone through. They sent almost a 10-person team from the CDC into the state to manage that part, to help local public health. And our local public health folks just did a bang-up job of figuring all this stuff out. Who's high risk? Who isn't? Who needs to be monitored every day? Who doesn't? You're going to be monitored for 21 days. You can't go to work. I mean, we had that level of stuff. Okay. So we had about 180 total people, and out of that 180, 172 were healthcare workers exposed.
Wow.
Patients' own family members did not seroconvert because at the stage they were with him, we figured the viremia, the level of virus wasn't that bad, wasn't that high. So we had about 67 healthcare workers in one part of the state exposed, with 50 of them being high risk exposure, missing PPE or something like that. In our facility, about 68 people were exposed. Of them, about 30 some were high risk. And I was one of the exposed. So I worked in the unit. I dealt with all the waste. I did the disinfection. So, I was monitored every day, got this little text every day, and had to get on an app and report to public health every day at 10 o'clock for 21 days. Signs and symptoms, anything, all that kind of stuff. And so, what was a very few hours, about 36 hours total at our hospital, ended up a whole month worth of effort and work. But the good news is not one of the 180 people that were exposed were sickened. And that's very fortunate. And I think some of it was because we contained it at its highest and most contagious. And everything else was just kind of fortunate. You know what I mean? If this was Ebola, things probably could have been much worse, which makes me scared, you guys, because there's Ebola circulating right now over in that continent. There's this disease. There's other things happening now. I'm very, very, very concerned about the posture of the U.S. healthcare infrastructure currently to be able to detect, deal with, and, prevent something like this from being worse than it is. The readiness, the money not being there to help, and the information exchanging, all of these things are very concerning to me. And this is not anything political, gentlemen. I'm not a political person. I'm a healthcare professional who's just retired for the third time, seeing it from the front end. Okay. I'm concerned, and our infrastructure has to be maintained and enhanced. It just does, right down to everything, all levels, EMS, transport, you name it.
We may, because of time, need to wrap this session up, but I think maybe a future session talking about some of those transitions and challenges and things for people to look for might be in order. But we certainly appreciate, I think your absence was felt by us, but I mean, the need was greater, far greater in what you addressed and how you addressed it. And I think the fact that you're now going out and sharing that information and kind of reigniting in a kind of story form what can happen to make it real for people is so important. So if people want to reach out to us, so I'm going to kick it to you, Mike, about our contact information and emails that you might be able to, depending on the amount of inquiries, you might be able to direct them towards additional resources or be available for conferences or workshops, relatively speaking, because you're retired again.
That's right, man. Yeah. I mean, probably in the description, we're going to try to put some links in there so people can look this stuff up. The National Special Pathogens System of Care, NSPS, NETEC, National Emerging Special Pathogens Training and Education Center, all that stuff. We'll put that down in the links below so people can get a hold of the information that they need. And bottom line is, know the system, who to call, get a relationship established. And everybody in the healthcare world right now, you have to do the 3 I's. Do you everybody remember what the 3 I's are, Chris?
I'm retired.
Identify.
No, I'm retired. I'm still retired.
Isolate.
Inform.
Hell, go, man. Do it.
Inform.
Let's see. Identify, isolate, and inform. Right?
Very good, Al.
Yeah,
identify, isolate, and inform. The 3 I's should be done by every healthcare institution, no matter what level you are in this country, and then know who you're supposed to call. Who are you supposed to call?
And I want to say, because we say this, and I truly mean this, we say this to our military, thank you for your service. Mike, Chris, and I know, and some of our listeners who are in emergency preparedness know what you went through. Thank you for your service, because I think the facility and the patient and all the coworkers that you dealt with were certainly fortunate because you were there. And I truly mean that sincerely. So thank you for
no big deal, dude. You do it too. This is the way we're all cut from the same cloth, you guys.
Yeah, we missed you in the podcast, but we're certainly glad you were there.
Hey, absolutely. Well, you do what you got to do, man. So anyway, 3 I's and travel screening, 24/7, 365 on entry into the system. Those are the keys. That maybe could have made a difference in this case had it been identified quicker. I don't know. time is your biggest enemy with these deals. The more time you take to get it nailed down,
So
it's unfortunate.
if people want to get a hold of us, if they need to, there's the description for the podcast, but they can also contact us at readiness.rewired@gmail.com. And we also want them to subscribe if they're so inclined, so they can get these sent to them automatically, these episodes. And I think there's a like button that you probably find on YouTube or wherever you're getting your podcast. And if you could give us a thumbs up or a thumbs down to indicate whether we're on task or not, and let us know by email.
I think Mike says that. I think Mike says that a little better when he closes us out. With the thumb. Mike, give us a thumbs up and thumbs down routine there. Hey, if you like us, give us a thumbs up. If you think we suck, give us a thumbs down.
If we think we suck, there you go.
Yeah. I mean, and that's the way it is, man. We want to know.
Well, thanks for letting me come back, guys.
Absolutely.